Hi everyone, my name is Gurjat Basra and I'm the Manager of Patient Programs, Research and Advocacy here at Lymphoma Canada. I'm very pleased to welcome you all to today's breakout session on diffuse large B-cell lymphoma, also known as DLBCL. Just before we start, I want to go through a few housekeeping items. So this Zoom software does not allow you to access chat features or turn on your microphone. So if you do have a question, this session will be followed up by a live Q&A session. So please keep your questions in mind and be sure to attend the aggressive non-Hodgkin's Q&A afterwards. So to introduce our speaker today, we have here Dr. Shannon Murphy. And Dr. Shannon Murphy is a hematologist and assistant professor at Dalhousie University and practices at the QE2 Health Sciences Center in Halifax, Nova Scotia. Prior to joining the Division of Hematology and Hematologic Oncology in Halifax, Dr. Murphy completed her internal medicine and hematology training at Dalhousie University, followed by a one-year clinical lymphoma fellowship with BC Cancer in Vancouver. Her practice focuses on lymphoma and chronic lymphocytic leukemia. So thank you, Dr. Murphy, for joining us today, and you can get started as soon as you're ready.
Great. Thank you very much. So thanks very much for having me. I'm very pleased to be able to present this breakout session on diffuse large B-cell lymphoma. So we'll dive right in. And as Gurjot mentioned, if you wouldn't mind, just jot your questions down as we go along, and I'll be very happy to answer them at the end as part of our discussion. These are my financial disclosures. So objectives for today's talk will be briefly to review non-Hodgkin lymphoma, and then we'll go more in depth through diffuse large B-cell lymphoma or DLBCL. Within that, we're going to talk about the diagnosis and staging, as well as the prognosis of DLBCL. We will review current treatment strategies, and we will discuss where therapies are heading and have a look at some of the emerging therapies in this space. So just as a reminder, lymphoma is a cancer of the lymphocytes. And so really what that means is that lymphoma involves overproduction and then proliferation of abnormal lymphocytes, which are one type of the white blood cells that are produced in your bone marrow. Lymphocytes are part of our immune system, and they can be overproduced, they can grow in the setting of lymphoma unchecked and wreak havoc. This is just a schema of the lymphatic system. So these are all tissues that are lymph or involved in the circulation of lymph fluid in the body. Our lymphocytes are made in the bone marrow, but then some types of lymphocytes will go and live elsewhere. And they are integral in the immune function in the body. And when they are overproduced, as you can see, just having a look at how lymph is distributed through the body under normal circumstances, you could see that lymphoma could crop up really anywhere. And because these lymphocytes are constantly circulating, and are also circulating in our blood, really lymphoma can affect any tissue. In terms of the types of lymphoma, we divide lymphoma into two broad groups, being Hodgkin and non-Hodgkin. And then we further subdivide non-Hodgkin lymphoma into those slow-growing entities and fast-growing diseases, which sounds quite simple, but in fact, it really is quite a complex picture. There are more than 40 different types of B-cell non-Hodgkin lymphoma. There's almost 30 different types of T-cell and natural killer cell non-Hodgkin lymphoma. There's even 4 types of Hodgkin lymphoma. So there are really lots of different ways that lymphoma can manifest. And each of those lymphomas really has distinct characteristics and often requires a different treatment. The focus of our talk today will be non-Hodgkin lymphoma, and then within that, diffuse large B-cell lymphoma. And so, as we can see, just popping back here for 1 second, the B-cell non-Hodgkin lymphoma space does have the most types of lymphomas. And certainly it is the 6th most common type of cancer in Canada. So non-Hodgkin lymphoma as a whole, but the B-cell non-Hodgkin lymphomas are more common than T-cell or NK cell. And these types of lymphomas are usually seen in older adults, with most patients being diagnosed in their mid-60s to 70s. Somewhere around 12,000 Canadians will be diagnosed with non-Hodgkin lymphoma in 2024. That's an estimate from the Canadian Cancer Society, so affecting many, many Canadians. And then of that, diffuse large B-cell lymphoma represents the bulk of non-Hodgkin lymphoma that we see. So lots of different types, certainly some are more common than others, but diffuse large B-cell lymphoma really is the most common. And now this schema was created based on American data. It was published back in 2006, so it is a little bit older, but the epidemiology of non-Hodgkin lymphoma and of diffuse large B-cell lymphoma follows a very similar pattern in Canada. So what is diffuse large B-cell lymphoma? Well, it is an aggressive or a fast-growing lymphoma, so a fast-growing cancer of the B lymphocytes. It is treatable and it is potentially curable. So we are able to treat diffuse large B-cell lymphoma effectively so that in a percentage of patients, and fortunately it is most patients, can be treated with the expectation that their lymphoma will never come back. And so when I say most, I mean more than half, and we'll talk about that in a minute. But it is treatable and potentially curable, and that's very important. It is also usually symptomatic at diagnosis. So when patients are presenting with faster growing lymphomas, usually they will have symptoms that are attributable to their disease. So you're sick because you have the lymphoma, and that can express itself in some characteristic ways. So certainly many patients will present with enlarged lymph nodes, lumps or bumps or masses that are new, that are noticeable, that aren't necessarily uncomfortable when they're first discovered, but certainly if they are growing, could become uncomfortable. They can be uncomfortable when they first appear if they're growing in a small space or somewhere that pushes on something else. And these patients with fast-growing lymphomas, and DLBCL is our prime example, can experience what we put in a category as systemic symptoms. These are your B symptoms. And B symptoms are fevers, weight loss, and drenching night sweats. I've tagged fatigue onto that list because it's quite a common symptom as well. But those classic B symptoms or systemic symptoms would be fevers, and these are fevers that occur outside of infection. So no infection, not necessarily infectious symptoms, but fevers that are happening regularly. These are often kind of a cyclical fever that happens roughly around the same time every day. We're going to call a fever a temperature of 38 degrees or higher. And typically, we would say fevers are recurring for them to be associated with lymphoma. Weight loss, so unexpected weight loss. So weight loss for no other reason. You weren't trying to lose weight, but it seems to be coming off. In some cases, people notice and actively try not to lose weight, and it continues to come off. And we'll characterize that unexpected pathologic. So in the setting of illness, that weight loss is going to be 10% or more of your body weight within 6 months for us to say, yep, that's suspicious for a systemic symptoms associated with lymphoma. And then a drenching night sweat, which can be hard to pin down, but really, if you're having a drenching night sweat, often people will say they feel as though they had a bucket of water thrown over them at night, needing to change pajamas or sheets or both, and happening consistently, so at least a few times a week, usually for a period of about a month. That's what we would expect from a drenching night sweat. But for most people, one drenching night sweat is going to be pretty noticeable. So you certainly don't need to wait a month before mentioning that to your physician and keeping an eye on what might be going on. And then fatigue. Lymphoma, like any illness, can make you feel unwell. And sometimes that's hard to characterize. You start to lose some of your energy, difficult to do work tasks, maybe hard to exercise the way you used to exercise. Some people will experience difficulty with their usual activities. So now short of breath going up and down stairs, where maybe that was easy before. Perhaps you're someone who walks regularly, who has been doing some kind of a regular exercise routine, and now that's really hard or impossible. Those types of symptoms can be seen with DLBCL. So you have a symptom, you have a lump or a bump, you're going to take it to the attention of your family care practitioner, whether it's a family doctor or a nurse practitioner. You're going to see someone, maybe it's a walk-in clinic, and we're looking to get to the bottom of it. If you have a lump or a bump, which is how most people will present, or you have an illness, the non-specific symptom, you have a B symptom, but we can't find the lump or a bump, then we're going to look into it. And at some point, people will end up having some imaging. So if you don't have a bump we can feel with your hand, we're not sure what's going on, often that will lead to a scan. And if a scan reveals a lump that shouldn't be there, or an enlarged lymph node or a mass, that will lead to a biopsy. And so a tissue biopsy is going to be the gold standard for diagnosing diffuse large B-cell lymphoma. And that tissue is often a lymph node. Sometimes it's soft tissue. So sometimes a mass is growing somewhere, not clearly a lymph node, or it's growing within other soft tissue like a muscle or a bone or an organ. Sometimes it's in the skin. So more rarely, but it can happen, you may have a cutaneous, so a lymphoma that develops in the skin that is still diffuse large B-cell lymphoma, but a bit of an unusual site. Maybe it's involving your gastrointestinal tract, so it's somewhere along your intestinal mucosa, so the tissue that forms your stomach or your small or your large bowel. And it can be in the bone marrow. And so finding the involved tissue and then biopsying it is the very important step in diagnosing DLBCL. And in many cases, it will be a lymph node or a mass. And so likely if you're being diagnosed with DLBCL, you're being referred to a surgical service of some type. And if we have a big enough mass or an easy enough to get at lymph node, we're going to try to take the whole thing. So it would be really nice to have a whole lymph node to really see the tissue to get a good, confident diagnosis. But in some cases, that's not possible. And when we can't get the whole lymph node, or you have maybe a lymph node in a bit of a tricky spot to get at, then you may be seeing interventional radiology, who are specialized radiologists. So physicians that do imaging, but they have special expertise in using that imaging to guide a core needle biopsy. So they're going to take a needle and sample a tissue using imaging guidance to make it as safe as possible. And they're going to use that needle to take usually 4 or 5 samples of that tissue to get to a diagnosis. Our excisional biopsies are often by the ear, nose, and throat service if they're sampling lymph nodes in the head or the neck. General surgery can help to sample lymph nodes, maybe in the armpits or the groins, or if they're in the belly. Thoracics can help to access lymph nodes that are involving the chest or in areas around the lungs, and so on. Once we have that tissue, we work very closely with our colleagues in hematopathology. So we have specially trained pathologists who look at lymph node, soft tissue, and bone marrow biopsy samples, looking for lymphoma cells and isolating them, and then looking at both the way they look under the microscope, but also the proteins that the cells express on their surface. And they'll usually get some clinical information from us in hematology to come to that diagnosis together. So once we know for sure that we have DLBCL, it's important to know where the lymphoma is in the body. So often before you had a biopsy, you probably had some imaging done, but we really want to have a good look at the whole body to know where the lymphoma is. And it's good to have a starting point before you start treatment, so that when you finish your treatment, we can re-image to know for sure that it has gone, hopefully, but also to know if there is residual lymphoma, where is it? What are we going to do about it? And to have a look at the rest of the body and see what else may be going on. So when you first are diagnosed with lymphoma, you'll often have staging imaging, usually with a CT scan and a PET scan. So a CT scan is excellent for anatomic imaging. So that's literally the size of the lymph nodes. It's a really good idea, a really good technology to get a really accurate size of lymph nodes, of organs, of soft tissue masses. And then the PET scan, which stands for positron emission tomography, PET looks at metabolically active tissue. So it involves getting an injection of a nuclear tag and then sitting around for a little while that tag is taken up by the tissues. And then you have a scan looking for where that tag is showing as bright in the body. And then you'll have a specially trained nuclear medicine radiologist read that scan to know what tissues that are metabolically active normally, like the heart, the bladder, the kidneys, the ureters, the brain, those should look bright, but areas that are bright and shouldn't be bright, and how bright they are compared to other tissues. So they'll give us an idea of where those active lymphoma cells are in the body, and then they use a CT scan to make a correlate with the anatomy. So very complex, but very, very interesting. Some patients may have an MRI, and we use MRI to really get a good look often at the brain or the spinal column, the spinal canal. And there are some regions of lymphoma that increase the risk of involvement in the central nervous system, so in the brain or in the spinal cord. And some people will present with symptoms that are concerning for brain or spinal cord involvement of their DLBCL. So really important for us to look for that on imaging with MRI, because we do treat DLBCL a little bit differently if it's involving the central nervous system, so the brain or the spinal cord. And so some patients where there is suspicion or risk of that involvement, we may do a lumbar puncture as part of staging, which is where this is a spinal tap, you may have heard it called. So literally a needle sampling of the fluid that bathes the brain and the spinal column in order to look for lymphoma cells. And then sometimes you may have a bone marrow biopsy as part of your staging. And so we used to do a bone marrow biopsy with every new diagnosis of diffuse large B-cell lymphoma in order to see if the lymphoma involved the bone marrow. But PET technology has improved to the point that for the most part, we can detect diffuse large B-cell lymphoma involvement on PET scan. So you may have a bone marrow biopsy if PET wasn't available, or if there was a question on PET, if it looked maybe involved, maybe not involved, then you may have a bone marrow biopsy at that time. And if you had a bone marrow biopsy before treatment, it's also possible you may have one at the end. So you may have a staging bone marrow. So definitely imaging, and then sometimes a bone marrow, sometimes a lumbar puncture to determine where in the body is the lymphoma prior to starting treatment. And the reason that staging is important is because stage of DLBCL will often guide treatment. Staging, we do stage lymphoma using Lugano classification, which gives us a stage 1 through 4. And 1 being just one node or one little group of regional lymph nodes, so limited stage, or one area outside of the lymph nodes. You can have more than one nodal group, but on the same side of the diaphragm, so either above the diaphragm or below the diaphragm, and still be limited stage, stage 2 disease. You'll see there's a little star next to stage 2 bulky. And the reason is, so in lymphoma speak, in DLBCL, we consider your DLBCL to be bulky if there's an area of involvement that is 10 centimeters or more. So if you have an area, whether it's one lymph node by itself or a couple of lymph nodes stuck together, making a bulky region of 10 centimeters or more, let's say that that's in the chest. So you have a bulky area in the chest, you have a couple of areas of lymph nodes in the neck. So if that bulky area wasn't bulky, it was just a couple of lymph nodes in the chest and a few lymph nodes around the neck, we would call that stage 2. But if that lump in the chest is 10 centimeters, then we're going to give that the term bulky. And even though that's going to be stage 2 with bulk, we're going to treat that as advanced stage disease because that's a big clump of lymphoma. We want to make absolutely sure that it's gone. Otherwise, your advanced stage disease is going to be lymph nodes involved above and below the diaphragm with no involvement outside of the lymph nodes. Spleen doesn't count as outside the lymph nodes because it's spleen tissue. So nodes above and below, spleen or no spleen, that's stage 3. Nodes above or below and involvement outside of the lymph nodes is going to be stage 4 disease. And what's most important is that stage 4 lymphoma, and especially stage 4 DLBCL, is very different from some stage 4 solid tumors like lung cancer or gastric cancers, colorectal cancer. Stage 4 DLBCL is still considered treatable and potentially curable. So that is important to know. But stage can affect prognosis, so it's important for us to get that information to help us to predict how disease might behave. Which brings us to prognosis. So we've done our diagnosing and our staging. We're going to use that information to help predict how disease might behave. And the tool that we use most often at my center here in Halifax is the Revised International Prognostic Index, or the RIPI. And the RIPI is a revised version of the plain IPI, or the original IPI, which is really a prognostic score which takes certain disease and patient features into account in order to try to predict how disease will behave and how easily treatable it may or may not be. And this prognostic score in particular was validated in large cohorts and even more recently through a study done in BC, in Vancouver, out of BC Cancer. Still not terribly recently, I think it was 2007, where they looked at Canadian data. Was this a valid prognostic score? And it indeed was valid in predicting sort of who was at higher risk and who had better risk disease. So we take into account and we give a point really for patients lymphoma that sort of ticks each of these boxes. So if age is greater than 60 years, you will get a point on the prognostic index. You get a point for advanced stage disease and an ECOG status of 2 or higher. ECOG stands for the Eastern Cooperative Oncology Group, and that's a research group. And the ECOG status refers to a performance status. So we have different ways in cancer care to describe function. Because it's a good idea to have a measure of fitness, how well someone is, before we consider giving an intensive treatment that could make someone unwell. So we want to know where we're starting from. And also you can think about it, if we're thinking about prognosis, someone who was unwell or is unwell from their disease, it may be a little bit harder to treat. Maybe their disease is more aggressive. That may be a feature of disease behavior, and that may predict how things may go down the road. Okay, so an ECOG status of 2 means that a patient is up and around for about 50% of the day. So about half the day out of bed, right? Up and around is out of bed, but unable to do work tasks, but able to do personal care. So starting at that level or higher, so a higher score means less function. So either more time in bed or needing more assistance. Okay. And then lactate dehydrogenase, an elevated LDH, we call it for short, will get you an extra point. We use LDH in lymphoma as a marker of cell turnover. It's not the only thing that it measures in the body, but it can certainly measure that. And in the setting of active lymphoma, LDH can be a marker of disease activity. So as you might think, if you have cells that are rapidly dividing, you have abnormal cells that are growing or lymph nodes that are growing, that's a lot of cell activity. And so you may have an elevated LDH, and that's quite common in DLBCL, and it gets you a point on the RIPI. And then if you have more than one site of involvement, so lymphoma in more than one spot outside of the lymph nodes, then that also gets you a point on the index. And what does that mean? Well, really, what it can separate groups into is patients who have or disease that is associated with very good risk, or poor risk. Okay, and that's literally how many points you're getting on the RIPI. We can put patients into those three groups. Now this is the study. This is the Canadian study done in Vancouver, published in 2007. And using the RIPI, this is how they were able to separate the groups. And if we just look at those curves, not even thinking too much about the numbers, but you can see that the curves separate really quite nicely. None of them really look like they're overlapping, except maybe good and very good, very close to the origin there. But certainly we can see that patients in the very good risk group do the best. Patients in the good risk group still do quite well. And then there's a pretty big separation from those who have poor risk. But if you can follow it out and make an invisible line between that 0.5 or the 50% survival, I do think it's important just to look and see, even back in 2006 and 2007, when they were preparing this report, the patients that were included, even those in the poor risk group, at 4 years out from their treatment, more than half of them, I think you can probably see my cursor. So if we go out here with the 50% line, that's still over 50% of them hadn't yet had progression of their disease. And certainly at 4 years out, more than 50% still alive, and there's a little plateau in that curve. So, certainly there is a percentage of patients with poor risk who are not doing as well as the very good and good, but still having a proportion of those patients with poor risk, more than half, are still doing quite well. So that's good, but of course we always hope to do better. And how we're going to do that is through treatment. And what we'll talk about here is we'll start with our tried and true, our standard of care frontline treatments for diffuse large B-cell lymphoma. We'll talk about that. We'll talk about treatment at relapse, what we're doing now, and what we may be moving to doing in the future. So our first line treatment, when we say first line, this is the first treatment that you get when you are diagnosed with DLBCL. And there's been a lot of attention in recent years on how we might be able to improve on that first line therapy for DLBCL, because our standard of care has been this acronym, this chemoimmunotherapy that we call R-CHOP, for more than 20 years. And it's been the standard of care because it works quite well. It is a chemotherapy backbone. So CHOP is 3 chemo drugs and a steroid. And we give that in combination with an anti-CD20 antibody, an immune therapy called rituximab. CD20 is a protein that B cells express on their surface. Then anti-CD20 antibody targets B cells. And so this immune therapy targets those cells, and the chemotherapy helps to kill them. So they both work together really quite well. And the biggest improvement in frontline treatment of DLBCL was when we started being able to use rituximab in the very early 2000s. It made a huge difference. And since that time, in the last 10 years, maybe 15, we've really been looking at, is there a better first-line treatment? And so far, we really haven't found one. There have been a number of studies looking at, are there other drugs that we could add to R-CHOP to make it more effective? And in some cases, you maybe get a little bit more effectiveness, but you also get more toxicity. And so that really hasn't turned into a better therapy yet. We have also looked at substituting some of the ingredients to see if that might be better, but so far there isn't one regimen clearly better than R-CHOP. The closest that we got, and I haven't included a slide on it, but the Polarix trial a couple of years ago looked at a drug called polatuzumab, which is an antibody, in combination with R-CHOP, but taking out the O, which is a drug called Oncovin, which we also call vincristine. And so no vincristine, polatuzumab, R-CHP, and compared that with R-CHOP to see if it was better. And interestingly, it seems like for a certain patient, there's a percentage of patients who may get a little bit better progression-free survival. So that's survival without progression of their disease or relapse, but it didn't turn into an overall survival benefit. And that progression-free survival was only about 6% better. And so there are some places in Europe that are using this regimen, but it is not a regimen that we are using in Canada, at least not at this time. So we are using R-CHOP, and the way that we are using it, so R-CHOP is given in one day, once every 21 days, so once every 3 weeks. And for advanced stage disease, we do that 6 times, or we give 6 cycles. For limited stage disease, so for someone who has stage 1 or stage 2 disease, no bulk, then we have options. We can do 3 cycles and involved field radiation, or we may choose to do 4 cycles with or without a couple of extra cycles of rituximab. We had a trial a few years ago called the FLIER trial, which compared 3 cycles plus radiation to 4 cycles without radiation. And they had a couple of extra cycles of rituximab, which we have seen since then are perhaps not necessary. And those patients did quite comparable. So it's, it'll always be a conversation between you and your physician on what's going to be the right choice for you, depending on where your disease is, the size, the location, your symptoms. One of those may be a better option than another, but very interesting to have that choice if it's appropriate. Okay, so R-CHOP. And then there's a couple of different ways we can give R-CHOP depending on patient and disease features. So for example, for our older patients with DLBCL, and when I say older, usually we're going to say about 80 years or older, then we will often reduce the doses of that CHOP chemotherapy because it is intensive therapy. And even if you are a really fit 85-year-old, you will have less reserve than a really fit 65-year-old. You just will. You've been on the earth for 20 more years. Your body has just had a little bit more wear and tear. So even if you're very, very well, we're going to dial that back a little bit. And sometimes what we might do if patients do really well is we may be able to turn the intensity dial up a little bit down the line, but it's always going to be balancing efficacy of treatment with tolerance, right? So we want to be able to get rid of that lymphoma and have a nice healthy patient at the end, as much as possible. And we do have validated evidence that shows us that dose reducing that CHOP chemotherapy in older adults is still very effective. So we've looked at it, we've studied it, we know that it's safe to turn it down a little bit in those older adults, and we can still have excellent efficacy. Similarly, because this is intensive treatment and we're using drugs that can have a lot of significant effect, and this is a disease that's often diagnosed in older patients, right? Patients in their mid-60s or older. Some of those patients will have experienced some heart trouble. And one of the drugs in the CHOP is a drug called doxorubicin. And doxorubicin is an anthracycline chemotherapy, and that word doesn't have to mean anything to you, but anthracycline chemotherapy can be hard on the heart muscle, okay? And so it can cause heart failure, which is really just reduced heart pump function, right? Your heart is a muscle, pump moves the blood through your body. And if your heart muscle doesn't pump well, then certainly that can slow down a number of processes. And so patients who have previously had heart attacks, patients who have significant coronary artery disease with no heart attack, patients who have low heart pump function for other reasons, they're at increased risk of heart injury from that kind of chemotherapy. So for those patients, for all comers, we're going to check your heart function. Just in case, you may not know that you have low heart function. We're not going to take any chances. You're going to have a test, sometimes an echocardiogram, which is an ultrasound of the heart, and sometimes a test that we call a MUGA, or a wall motion study, which is looking at how your heart pumps and how much blood it pumps. And as long as your heart pumps well, then we're going to give you, and you haven't had a significant history of heart or heart valve problems, then you'll get your R-CHOP. But if there's any trouble with your heart pump function, or you do have a significant history of heart muscle or heart valve trouble, then we may substitute a drug. So we may swap that doxorubicin for a drug called etoposide, as etoposide is also an effective form of chemotherapy, but it doesn't have that same hard effect on heart muscle. And we do have some studies looking at what we call our COP, when we're subbing out, we're taking out that doxorubicin, we're giving etoposide instead. And we see that the risk to the heart muscle for patients with a history of heart disease does seem to be safe and still effective. Okay, so we can swap out the doxorubicin for etoposide if we have to. The other modification we might make to R-CHOP is for those patients with DLBCL that fall under the category of a little bit more aggressive disease. So when you're diagnosed with DLBCL, we're going to do some testing to see if your disease has a genetic rearrangement that makes it a higher grade or an even more aggressive form of large B-cell lymphoma that historically we have called double hit. You may have heard of triple hit lymphoma. Those patients who have double hit lymphoma, their disease is likely a bit more aggressive. And we have some evidence that shows us when it's appropriate, we might want to make the treatment even more intense by giving a regimen called R-EPOCH, or dose-adjusted R-EPOCH chemotherapy, which is given as an inpatient. Now, it's not given as an inpatient because it's more intense. It's given as an inpatient because it's an infusion. So it's a long infusion that's given just over 4 days. So you need to be in hospital that time so you can be hooked up to the IV. So it's given very slowly, but it does drip in over those 4 days. And then patients go home in between their treatment. Okay, so some patients may be offered that R-EPOCH chemotherapy if the disease looks a little bit more aggressive, and there's some evidence to support that. And I think Dr. Johnson is speaking today on those different types of aggressive large B-cell lymphomas. So what we can expect after that first-line treatment, so first-line R-CHOP for DLBCL, most patients, so on average about 70% of patients will have a complete response. So that means they'll get to the end of their 3, 4, 6 cycles of R-CHOP chemotherapy, will re-image with a PET scan, and it will show no evidence of active lymphoma. That's excellent, definitely the goal. But there will be 10 to 15% of patients that will be refractory, which means they will have active lymphoma at the end of that therapy. So not all gone. Pardon me. And there will be a percentage of patients who initially experience a complete response, but then go on to relapse. Okay, and that's probably 15 to 20% of patients who will experience a relapse of their disease. And so, you may look at those numbers and say, well, 70% of patients will have a complete response and their disease won't come back. And, that is really good. And it is. But that leaves 30% of patients who won't. And if you take just 100 people, it's 30 out of 100 of those people. And I think that you will agree, if you're one of those 30, that's not good enough. So we are striving to improve on these numbers through things, as I mentioned earlier, trying to improve that treatment out of the gate. But then we're also working really hard to find better solutions for patients whose disease wasn't adequately treated by that first-line chemoimmunotherapy, and for patients whose disease comes back after initial period of response. So if you still have disease at the end of treatment, or if you have disease that comes back afterwards, we're going to call your disease relapsed or refractory. And we do have a standard of care approach for patients right now who have relapsed or refractory disease, but that approach is in flux a little bit right now because we are starting to have some really good options for patients with relapsed refractory disease. So in my center, and I think most centers in Canada will initially take a look at you, the patient, first and say, okay, you've just gone through some intensive chemotherapy. We're going to do an assessment and see, how are you doing now? What's your function like now? Because you still have lymphoma or your lymphoma has come back. What we'd like to do, if you're well enough, and if you're up for it, is to give you some salvage therapy. And so salvage typically is chemoimmunotherapy, so usually combined with rituximab, again, a different chemotherapy backbone. So you'll get usually another 3 chemo drugs in combination. Maybe you may have heard of some of these regimens. We use RGDP typically at our center. There's other regimens, R-ICE, R-DHAP, that are also excellent salvage, but rituximab in combination with some chemotherapy, and we're going to do that and see how disease responds. So typically you'll get a couple of cycles of salvage therapy and then repeat imaging, PET and CT scan, and see, okay, is it working? Okay, and if it is working, so if the salvage therapy is getting rid of the lymphoma and you're having a good response, so typically we'll say more than half the disease is gone, you're doing well, then for patients who respond, typically they will go on to an autologous stem cell transplant. That's your own cells. If you're not responding well, then likely your disease is looking maybe resistant to chemotherapy. So we're going to go down the path to a cellular therapy with CAR T cell therapy. And so right now in Canada, CAR T cell therapy is funded for DLBCL, that is refractory or has relapsed, after 2 prior lines of therapy. It has recently been approved for refractory DLBCL in the 2nd line. It's not funded yet, but we are keeping an ear to the ground for that. Does that make sense, right? If you have a disease that responds to chemotherapy, then to give them a chemo-based treatment like an autologous stem cell transplant, we're going to talk about that in a second, that's a good plan. But if you have disease that's not sensitive to chemotherapy, so particularly those patients who didn't have a good response to that first line chemo, patients who have had relapse, but the salvage therapy isn't doing it, they're having an inadequate response, their disease is not sensitive to chemotherapy, then going down another pathway with a cellular therapy like CAR T cell therapy, which is an immune-based therapy, sounds more appropriate. So in both scenarios, an auto stem cell transplant and CAR T cell therapy, we're using your own cells, but we're using them to do very different things. So an autologous stem cell transplant collects your own stem cells and then uses them as a rescue to regrow your blood cell counts, to repopulate your bone marrow after receiving high-dose chemotherapy. It is most effective for chemo-sensitive disease because it is a chemo-driven treatment. CAR T cell therapy does use your own cells. It's going to use your own T cells. But once those T cells are collected, they're going to be engineered to attack lymphoma cells so that it's the T cell doing cell-mediated killing when those T cells are given back to you. And that works most effectively for disease that is chemo resistant, though it can work, of course, for patients who have had chemotherapy before a disease has come back, because it's going to be everyone. Everyone's seen chemo before, but lymphoma that comes back, that salvage chemotherapy isn't effective, or as we're seeing for lymphoma that doesn't respond to chemo out of the gates, then a cellular-based immune therapy may be better. So what does that look like? So this is just a schema of an autologous stem cell transplant. And what happens is you'll get some medication to make more stem cells and push them out into circulation so they can be collected. You'll get a special IV, but there's no surgery. They're not collected in the adult world. We're not going to collect them directly from your bone marrow. We're going to take them kind of like a blood donation. Okay, and we're going to use a special machine that will separate the stem cells from your other blood cells. Other blood cells will go back to you. And then we're going to take those stem cells and hold on to them. Often they'll go in the freezer. So we're holding on to those stem cells, and before they come back to you, you're going to get some conditioning and you're going to get some high-dose chemotherapy, sometimes in combination with radiation therapy, to get rid of any lymphoma cells that may still be in the body, to really bring those the blood producing cells in the bone marrow, just get rid of them. We don't want any abnormal cells being produced, no live lymphoma cells left. So big gun chemotherapy. And then we're going to give you your stem cells back so that they can repopulate your bone marrow. Okay, so bring your cell counts down to nothing, give you your stem cells, regrow your blood cell counts. And that's given to you really just like a blood transfusion, so through an IV. Patients will stay in hospital for a period of time because, of course, cell counts are very low, risk of infection is high, needing some supportive care, and watching to ensure that population of cells regrows. With CAR T cell therapy, it's very similar and yet very different. Again, you'll have some pre-treatment. You'll have cells retrieved, they'll be separated, so T cells separated, other cells given back. And then in the lab, the CAR T cell will be created. So take your T cells and turn them into a chimeric antigen receptor T cell or CAR T cell using a gene. And so that T cell now will target DLBCL, okay? And then we'll expand that population as we want as many as possible. So we'll grow millions of CAR T cells in the lab and hold on to them. The patient will then get some conditioning treatments, and then the CAR T cells will be given back again like a blood transfusion, and those CAR T cells will seek out the lymphoma cells to kill them. So those are great options, but as you might imagine, they're also reasonably intensive options. And so autologous stem cell transplant or CAR T cell therapy may not be appropriate for everyone. And for those patients with relapsed refractory disease, we do have other options. The options I have listed are not the only ones, but there's that drug polatuzumab again. Well, our first evidence for polatuzumab was in relapsed disease, and that's the case often with new drugs. The first time we see it, it's in relapsed disease, and then if it works well, we try to move it earlier. So polatuzumab in combination with bendamustine and rituximab is very effective chemoimmunotherapy that is very effective in the relapsed setting. We don't consider it to be curative, but patients can have good responses. And it is a little bit less intense, a little bit more tolerable than that cellular therapy. So for an older patient, maybe a little less fit, that might be a nice example. Now it's still reasonably intense, right? It's not gentle, but certainly can be tolerable and effective. We do have other options, but it's good to know there is also an all oral therapy that can help to slow progression of disease, which we use in the setting of perhaps quite a frail patient who's been treated before, but would like to be at home and just try to slow progression of disease as much as possible with something that's going to be quite tolerable. So certainly we don't expect this to work robustly or for usually not a terribly long time, but it can slow progression of disease and hold on to quality of life with 3 oral medications, and it can be a nice option for frailer patients who would still like to try something. And then we have some newer options for relapsed and refractory disease, and you've probably heard some information about the bispecific T-cell engagers, or BiTEs, which are a cellular therapy that do kind of a similar thing to CAR T, but all inside the body. So you're given a drug, and the drug is bispecific, so it has 2 targets, and what it's going to do is it's going to take a DLBCL cell and a T cell and bring them together to sort of help facilitate that T cell killing the lymphoma cell. And they're very interesting therapies. They seem to be quite effective. We do have access and funding for them now in Canada and in Nova Scotia. So we have 2 products that are available to us now that, of course, are not compared head to head, but there's good evidence for both of them. And right now we can use BiTEs, or bispecific T-cell engagers, in patients who have previously had 2 lines of treatment. We can use this for patients who have previously had CAR T. You don't have to have had it, but you can. So a very interesting option now available. The drugs that we have are epcoritamab and glofitamab. They are very similar, but given a little bit differently. Epcoritamab is a subcutaneous injection, which is an injection under the skin. It's given indefinitely, so you stay on epcoritamab for as long as it's working for you and as long as it's tolerated. Glofitamab is given as an IV infusion. It's a time-limited treatment, so you go through a period of treatment and then stop and have a period of watching after that. So very interesting data on both of those, looking quite good. Always good to have options for patients when disease comes back. So very exciting to have those available and now funded. We do also have more options and are always looking for more options. We can use more traditional chemotherapy agents, either by themselves or in combination, for patients who have had disease come back multiple times. We have a couple of targeted agents which have been studied in combination, and there are some studies ongoing, a combination in particular of lenalidomide and tafasitamab, which has some activity, not hugely robust activity from the studies that we have, but some activity certainly in relapsed DLBCL, and more studies ongoing. So very interesting to know how best to use those drugs in relapsed patients. And then we have some emerging therapies. I talked a little bit about how we've been looking at what we can combine with R-CHOP up front. Well, we've looked at combinations up front, and now certainly there's investigations of combinations in relapse disease. So using BTKIs, which is Bruton tyrosine kinase inhibitors, that's ibrutinib, acalabrutinib, and zanubrutinib, those types of medications in combination with chemotherapy, and some studies in combination with immune therapies and targeted agents, looking to see what can we combine to be effective against DLBCL. New medications under investigation called BTK degraders, which are very exciting. There's some emerging information. They appear to have good effectiveness in relapsed B-cell non-Hodgkin lymphoma, but we're waiting for some more data to come out. But looks like exciting options and tri-specific antibodies. So we have BITES, and we're going to at least have more information on these trikes or tri-specific antibodies, which are similar but with 3 targets instead of 2. So looking at different ways to more effectively target DLBCL for those patients who need more options or better options. And I will just put in a plug here to think about considering a clinical trial. There is lots and lots of research ongoing. It's a very exciting time in lymphoma right now. And a clinical trial, if there is one available at your center, might be a great way to have access to some of the newer treatments earlier. And it is always a great way to help the next patient coming behind you, right? To get more information, to see what it is that we can do better, the treatments that we have coming in the pipeline, to contribute to our knowledge of the disease and how we're treating the disease. But it can be a really great option. It can be an appropriate choice depending on your disease, your situation, but always something to have in mind. So feel free, of course, to talk to your physician, your nurse practitioner about what may be coming down the pipeline. So I've been talking for a very long time, but we'll just summarize right now. DLBCL, or diffuse large B-cell lymphoma, is the most common B-cell non-Hodgkin lymphoma that is a fast-growing, treatable, and potentially curable cancer. Right now, our best first defense is still R-CHOP chemoimmunotherapy or similar variations, and it is still effective for most patients with DLBCL in frontline. The treatment landscape for relapse and refractory disease is ever evolving, and lots of excitement about cellular therapies and seeing that they are effective and looking at bringing them into earlier lines of treatment, but lots of very exciting things on the horizon. So certainly don't be shy. Ask us about what's coming. And I thank you very much for your attention today and look forward to hearing your questions.
Thank you, Dr. Murphy, for that informative presentation. For the audience to have your questions addressed, please be sure to attend the Aggressive Non-Hodgkin Lymphomas Q&A, which will begin in a few minutes. So thank you and see you there.